Hi there. Thank you for tuning in to Make Medical Easy. I am Prabuddha Goswami. I'm a pre-final year student at JIMS Bajbaj, and today we'll be having a short discussion on the pharmacotherapy of mood disorders. Okay, so this is a very interesting topic which inculcates both pharmacology and psychiatry. So, I'll try to make it as interesting for you as possible. Okay. So, when we talk about mood disorders, the most important mood disorder which we need to study is basically a wide variety of disorders which we call as the bipolar disorders. Okay. The bipolar disorders. So, what exactly are these bipolar disorders? Now, as the name suggests, bipolar refers to two poles. So, one pole we refer to as mania, and the other pole we refer to as depression. Okay. So, mania plus depression gives us bipolar disorders. Okay, so what do we mean by mania? Like we have a reduced need for sleep, increased need for energy, increased libido, more motivation, greater reward sensitivity, but lesser sensory motor grating. And with that we have racing thoughts and we are very aggressive. Whereas the exact polar opposite to mania is depression, where we have increased need for sleep. We are always drowsy. We have lesser energy, sexual drive, motivation. Our punished sensitivity, is through the roof, and with a more or less normal sensory motor gating. Whereas the sense of helplessness, is increased in case of depression. So, with the pharmacotherapy of mood disorders, our target will be to attain euthymia. Euthymia refers to a normal, healthy state of mind where we are neither maniacs, neither are we depressed. Okay, so what exactly is mania? Mania or hyperactivity, okay, occurs due to the overactivity of certain neurotransmitters, primarily dopamine in the brain. Okay, and why does it happen? It happens due to the disbalance in the calcium metabolism, which causes hyperstimulation of the brain. Okay, so we basically have four major pathways or tracks in our brain, the hyperactivity of which culminates into mania. And these tracks are the mesocortical pathway, the mesolimbic pathway, the tuberoinfundibular pathway, and finally the nitrostriatal pathway. Okay, so we have the mesocortical pathway, we have the mesolimbic pathway, we have the tuberoinfundibular pathway, and the nitrostriatal pathway. Okay, and so due to disbalance in the calcium metabolism, these four pathways have a very severe amount of hyperactivity. They're hyperactivated, which causes overactivity of neurotransmitter, mainly dopamine, which culminates into mania. Okay, so this is a very beautiful flow chart, okay, which tells us that how the neurotransmitter is broken down. So our dopamine stimulates the GPCRs, that is the G protein coupled receptors, which in turn goes and activates G protein. Now the G protein converts IP3 into into IP2. Okay, inositol diphosphate. Inositol triphosphate is converted into inositol diphosphate. Okay, and then inositol diphosphate is converted into inositol monophosphate and finally broken down to form inositol. Okay, now this free inositol, as you can see, then goes and combines with again inositol monophosphate, and finally we have PIP, and then from PIP we have PIP2. Okay, that is inositol, and that is phosphatyl inositol diphosphate. Okay, PIP2, which and then and this flowchart then again continues and continues. So this flowchart of the breakdown of the neurotransmitter and how it activates the IP3 DAG pathway is very essential in us understanding how lithium helps us to treat the cause of mania. Okay, so now here comes our friend lithium, and what does lithium do? Lithium is the drug of choice for the prophylaxis of mania. Okay, it inhibits the phosphatase enzyme. Okay, and what does phosphatase do? Phosphatase inhibition of phosphatase enzyme decreases the calcium production. Okay, and thus the mania is controlled. So lithium primarily has two roles. What it lithium underregulates or causes the understimulation of the dopamine receptors and the NMDA type of glutamate receptors. On the other hand, we know GABA is the inhibitory neurotransmitter. So our role must be to promote or to overstimulate or activate the GABA receptors. So this is the role. Okay, and then this is a very beautiful illustration, from osmosis. Here we can see how lithium acts. Lithium is inhibiting both IMPase and IPPase, which are the phosphatase enzymes respectively, which is causing decrease in the free inositol. Okay, And by reducing this free inositol, our PIP2 is coming down, thereby causing the reduction in the entire IP3 DAG pathway, thereby reducing the secondary messenger effects, and hence helping us to control the neuronal hyperactivity. Okay, and as we can see, there are a lot of pathologically hyperactive circuits as well, and these are controlled. And finally, this leads to euthymia or mood stabilization. Okay, now as you can see again, like I told you, lithium inhibits dopamine neurotransmission, neurotransmission, because obviously dopamine is the stimulatory, or the excitatory neurotransmitter, and promotes GABAergic neurotransmission, by increasing the GABA levels in the CSF and facilitating GABA release, and also upregulation of the GABA B type of receptors, and thereby with an increase in the inhibitory neurotransmitter, that is GABA, or gamma aminobutyric acid, like is the full form, we have controlling of our mood. Okay, so there goes our mania. Next of all, at the opposite pole of mania, we have what we know as depression. So depression occurs due to a deficiency of a particular factor which is known as brain derived neurotrophic factor, which we also call as BDNF. Okay, and this BDNF is important in the maintenance of neuronal plasticity. So if we have reduced levels of BDNF, our neuronal plasticity is lost, and that's what makes us go into depression, which is again a very common occurrence amongst us who belong to the medical fraternity. Okay, so BDNF, and so when we have a dysfunction in our brain derived neurotrophic factor, there are a lot of other subsidiary systems which are also affected, like you can see, there's a reduction in the HPA axis, increased energy intake, then there may be a cytokine storm and decrease in estradiol, all of which culminates into depression. Okay, so how does lithium act in depression? Lithium goes and inhibits a certain enzyme which we call as glycogen synthase kinase 3 beta. Okay, that's a very complicated enzyme name, I know, but you can also remember it as GSK3 beta, which would suffice. Okay, and this GSK3 beta is important, is essential or important for the breakdown of the brain derived neurotrophic factor into its metabolites. So once our lithium has gone and inhibited this enzyme, we'll have an increased amount of BDNF, right? And with an increased amount of BDNF, we'll have a better neuronal plasticity, thereby which will cure our depression. And like you can see, lithium is going and inhibiting this enzyme, thereby causing stabilization of the proteasomal degradation, and mitochondrial adaptation is also bettered. Okay, so this is an overall summary of today's discussion. This is a very short session where to prevent mania we use lithium, which is a drug of choice for prophylaxis. We can also use anti-epileptic drugs like carbamazepine and valproate. We can also use topiramate. Okay, and our antipsychotic drugs are also important to cure mania in case mania hits a pregnant mother, because as we know, lithium is contraindicated in pregnancy. Okay, and then on the other hand, in the opposite pole, we have depression. So again, lithium is the drug of choice for depression, and very importantly, lithium is the only drug which decreases suicidal tendencies in case of bipolar patients. And we can also use lamotrigine if lithium does not work, or to potentiate lithium's action, we can also use lamotrigine. Okay, so that, my friend, was a very short session. Thank you for your patient listening. And of course, before we diagnose ourselves with depression by listening to other people, we must ensure that we do not surround ourselves with a-holes. Okay, with that said, I take your leave for today. Thank you for your patient listening again, and I hope to see you in my next lecture. Okay, farewell.